Hello, I'm Roger Watson, and as you can see, I have a part-time position as an academic dean at Southwest Medical University in Luzhou in China. Obviously, because of the situation in the world over the last few years, it's been a few years since I visited either your university or anywhere else in China. But I'm very glad to be doing this today, however remotely, and what I want to talk to you about is some of my own research over the years into mealtimes and older people with dementia. First of all, I want to consider some background to the problem that I'm going to talk about today. It's reckoned that every 3.2 seconds, one person in the world is diagnosed with dementia. In other words, in the time it's taken me to present this slide, 5 or 6 people have already been diagnosed with dementia. It's estimated that at least until 2050, the number of people with dementia will grow. We're currently slightly beyond 55 million people with dementia. By 2030, it's reckoned in the world there will be 78 million people, and by 2050, when it's expected to tail off somewhat, it can't of course continue forever, the number of people with dementia is reckoned to be around 139 million people. Now, dementia is not a specific disease. It's a syndrome caused by a range of diseases. I'm not going to go into those now. You will already be familiar with them. The principal cause of dementia is Alzheimer's disease, but there are other conditions like cerebrovascular dementia and Lewy body dementia, which are also quite common and a lot of smaller, in terms of prevalence, forms of dementia. But it's a syndrome, and of course, being a syndrome across all these disease types, it does have some features in common. So what does dementia affect? Well, dementia affects intelligence, judgment and behavior. It also affects memory, and it also affects language. So it affects these by affecting different parts of the brain, principally the frontal, the parietal and the temporal lobes of the brain. It doesn't really affect movement too much. And the problems associated with these are threefold: intelligence, memory and language. The problem with decline in intelligence is that you lose your ability to solve problems. With the decline in memory, you become forgetful, and it's quite common for people with dementia to become lost. And in terms of language, people with dementia often have difficulty with communicating, both understanding and expressing themselves. However, beyond these cognitive disabilities, there are manifestations and problems associated with dementia, which of course is where we as nurses interact with people with dementia. We interact with them because of the problems of wandering. People with dementia often, as we said already, become disoriented and lost. There are problems of aggression, which can make people with dementia quite hard to manage, especially at home. They may become unfamiliar with their spouse or with their close family and become aggressive towards them. This may lead to injury. It may also lead to them being institutionalized in a hospital, both for their own protection and for the protection of those around them. But of course, that aggression can also be a problem for those of us working with people with dementia. Then there is the problem of incontinence, and it's usually functional incontinence in the sense that the signals of having a full bladder or a full bowel are gone, but also combined with memory loss and confusion. And finally, the problem or the issue that I want to talk about today are problems of feeding and nutrition. I prefer to talk about these collectively as mealtime difficulties. Older people with dementia do eventually lose the ability to know when they have to eat, and often have difficulty with the actual mechanical aspects of eating, and it can be a very distressing thing for relatives to deal with, and also for clinical staff to deal with. I've been working in the area of mealtimes and dementia now for more than 30 years, certainly since I was in clinical practice, and I left clinical practice in 1989 and then came into academia, and it's been the one constant thread of my work throughout all of my academic career. Incidentally, just for your interest, I have now retired from academic work, but I have recently been supervising PhD students who have been doing projects on mealtimes and dementia. And what I'm going to do, as well as reporting some of my early work, is to report some of that work here. There are clearly nutritional aspects of mealtime difficulty in people with dementia, and it's very common for people with dementia to lose weight, especially in the later stages. They sometimes go through a period of overeating. In the middle stages of dementia, that tends to be quite short, but then a longer phase of having difficulty with eating and losing weight. However, it's also worth saying that weight loss in dementia has some other causes. There's some organic cause of weight loss as well, and it has been observed to precede difficulty with eating. So it's a complicated relationship between feeding difficulty and weight loss and nutrition in dementia. However, we have an immediate ethical and legal issue here. The specific ethical and legal issues will differ in different countries, of course, because ethical and legal laws are not necessarily international. But for us as professionals, we have a problem. And the problem is we cannot interpret the actions of a person with dementia. We don't know why they are not eating. We don't know if they're eating because they don't want to, because they feel full, because they forget to eat. We don't know if this is some way of a cry for help, or if they genuinely do not understand that they need to eat. We don't know. And if we do know, then if we did know, even if we did know, then we have difficulty knowing what we should do. We don't know how to alleviate eating difficulty. The research in this area is very, very poor, so we don't necessarily know what to do. We don't know what constitutes force feeding. We tend to think of force feeding as holding someone down and forcing them to eat. But of course, if you're continually offering food, even gently on a spoon or on a plate, to someone who doesn't want to eat, that could be considered to be force feeding, certainly in some jurisdictions. And the other problem, which I'm not going to talk about too much today, but we don't actually know when to stop feeding a person with dementia. We have to face one big issue, which is that the person with dementia will eventually stop eating. And we then have to make the decision about whether we are prolonging their misery, or are we actually helping them by forcing them to eat in the later stages, or nourishing them by some other means. So these are big ethical and legal dimensions beyond the scope of my session today, but I just wanted to raise them. And I wanted to raise them because I want to very briefly consider one aspect of the feeding of people with dementia. And that is tube feeding. Now, in my jurisdiction in the United Kingdom, tube feeding is almost never used with people with dementia. but I have seen it being used in other countries. And I think it's worth noting as professionals, a review by Finucane et al. It's a very old review carried out in 1999, but it was definitive, and it was a systematic review of tube feeding in patients with dementia. And it's worth me just recounting all of these points here. Tube feeding benefits were as follows. There was no reduction in aspiration pneumonia in people with dementia, no effect on any clinical markers of nutrition, no improvement in patient survival, no improvement in decubitus ulcers, or pressure ulcers as we call them, no reduction in infection, no improvement in functional status, and no improvement in patient comfort. In other words, from the clinical point of view and from the research perspective, tube feeding is never recommended for older people with dementia. The feeling is not only is it not doing these things here, it may actually simply be prolonging or adding to their discomfort and misery. So I want to say that we should not be using tube feeding at all. But because of this, it's necessary and ethically necessary as an evidence-based profession to look at other ways of alleviating feeding difficulty. And this is where I want to turn to my own work. Now, in 1994, slightly before that, but we published the first paper in 1994, myself and a colleague called Ian Deary at the University of Edinburgh. We published a scale called the Edinburgh Feeding Evaluation and Dementia Scale. We called it the ED-FED scale. There are different versions of this. Originally it had 11 items, then it was reduced to 10 items, but 6 of those items are specifically about measuring the feeding related behaviours of patients. So there are different versions of the scale. It's used in different ways, but the basic scale, as far as I'm concerned, has got these basic 6 questions. Now, I'm not going to go into the ED-FED scale in any detail here at all, but it asks questions like, does the patient ever refuse to eat? Do they turn their head away? Do they spit their food out? That kind of thing. And it asks the clinicians to rate them either never, sometimes, or often. It's a fairly easy scale to use, and I was very pleased that it was referred to in the following report. In 2014, the Alzheimer's Disease International Association published a major report on nutrition and dementia, covering all aspects of nutrition and dementia. And they had a section on assessment, and that's what the ED-FED scale is used for. And they said the following about the ED-FED scale. They said it's the most widely used and best validated measure. And they referred here to the 10-item ED-FED scale, developed for those with moderate to late-stage dementia and brief and simple enough to be used in routine care. So they were actually recommending the use of the ED-FED in routine care. And it said also that the ED-FED has been subjected to extensive psychometric testing, demonstrating internal consistency, hierarchical scaling properties, confirmatory factor analysis, construct convergent discriminant validity, and also inter-rater reliability and test-retest reliability. So it's been thoroughly tested and used widely. I'm also pleased to say that it's been translated into a great many languages in Europe and in Japan, and it's also, I'm happy to say, been translated into Chinese. And this is the Chinese version of the ED-FED scale, the CH ED-FED scale. That was published in the Journal of Clinical Nursing, and if anyone is interested in finding out more about that, then you're welcome to contact me, and I can send you more information. I may even have a copy of the scale in Chinese. It's free to use. There's no copyright on it at all. However, I'm not here specifically to advertise the ED-FED scale. I want to talk more about some aspects of my own work and how the EdFed scale has been used in further research. Now, in 2005, I published a systematic literature review along with my colleague Professor Susan Green on feeding and dementia, a systematic literature review, and there have been several reviews since then which are much more rigorous and up to date, but this particular review gave rise to several strands of work, and what I want to do here is just summarize what the results of this systematic review told us. We retrieved a total of 67 papers, and only 13 of these addressed interventions aimed at helping older people with dementia to feed. All of the studies reported positive outcomes, and there was only one randomized controlled trial, and of course randomized controlled trials are the gold standard, and the fact that they all reported positive outcomes suggests that there may have been some reporting bias here. The most common intervention was music. There were no standardized interventions or outcomes across the studies, so it was very impossible to compare and to combine these studies in any kind of meta-analysis. None of the studies reported the use of power analysis to decide on their sample sizes, so the results may not even have been valid at that level, and also there were problems in some of the studies with confounding variables. There could have been any number of explanations for the outcomes. In summary, what I'm saying is that in 2005, the state of the science in mealtime research for older people with dementia was very, very poor, and there was plenty of scope for research. Now, in 2010, along with colleagues in Taiwan, I published this study, which was using spaced retrieval and Montessori-based activities in improving eating ability for residents with dementia. This is an interesting study for several reasons. First of all, it was the first truly randomized controlled trial and of older people with dementia with respect to feeding. So it's the first rigorous study. It's by no means perfect. It's a difficult area in which to do research, but it's been often referred to since then, and it was groundbreaking in that sense. And also the EdFed scale was used as one of the outcomes in this particular study. So what I want to do here is just to report briefly on those findings. But before I do that, I want to try to explain what the methods were that were used for the interventions in this study, a Montessori method and spaced retrieval method. These are both educational methods, in fact used with children commonly, in the case of Montessori method, and spaced retrieval is used for people with learning disabilities. Montessori teaching methods are a method which put children at the center of the educational experience. But the key aspect of Montessori is that it breaks down everything into simple achievements. So the attempt with using Montessori methods to help older people with dementia to eat at mealtimes was to break the tasks down into small, achievable tasks and then to build these together. That's a very much a quick overview of the Montessori method. Spaced retrieval, on the other hand, is based on spaced out repetition. The retrieval means the ability to retrieve that memory under some training. So, for example, first of all, instructions are given and then expected to be either recalled or repeated or carried out after a very short time of prompting it, maybe just a few seconds or even a few minutes. But gradually, over time, the length of time between the initial prompt and then expecting that action to be remembered and taken is increased, And this is in an effort to help someone with memory problems to try to remember how to do things, sometimes things that they were already able to do before their memory was affected. So, for example, in the case of mealtime difficulty with older people with dementia, it may simply be an instruction to pick up an eating implement like a spoon or a fork, and then spacing out the time until the person is able, in fact, to do the action without any further prompting. So that's the basis of spaced retrieval. And spaced retrieval appears to work within memory by working specifically on procedural memory, whereby skills and actions are learned. In dementia, of course, short-term memory is certainly badly affected, and sometimes long-term memory too, and all sorts of other aspects of personality and cognition. But it's considered, and it's been demonstrated through our own work and the work of other people, that procedural memory, the ability to relearn tasks, is not affected too badly in dementia. So spaced retrieval works on the procedural aspects of memory. So the results showed that after the intervention with either Montessori or spaced retrieval, the Edinburgh Feeding Evaluation and Dementia scores and assisted feeding scores for both groups were significantly lower. In other words, these interventions were actually lowering the feeding difficulty that was being observed in these patients. So the interventions were actually helping them with mealtime activities. And very much to our surprise, the nutritional markers using the mini nutritional assessment in the spaced retrieval group, at any rate, was significantly higher than that of the control group. So this was interesting to us, that not only were we alleviating the difficulty observed, we were also helping to improve the nutritional status of these patients. Now, I forgot to explain what Montessori methods and spaced retrieval methods are. Montessori method is a method of educating children, and it's a way of breaking things down into smaller tasks. And spaced retrieval is similar, it has some similarities to Montessori, but this is a way of prompting people and giving them time to learn from those prompts and trying to reduce the time needed to help them to understand what they're doing, and then hopefully with those prompts to allow them to eat by themselves. So I'm sorry to say there isn't time here to go into these particular methods in any detail. They will come up again later with one of my PhD students, but essentially they are educational and retraining methods that have been used in other situations, for example, for people with learning difficulties. So we consider that they could be applied, and have been indeed applied successfully, to older people with dementia. Now what I want to do is to turn to two other strands of work. One is a strand led by one of my doctoral students, Alvisa Palesi, who is from Italy, and the second strand was led by Salma Rehman from Pakistan. I'll report the work involving Alvisa first of all. Alvisa Palesi carried out for her PhD study a series of studies, and these were large retrospective studies using data gathered in the north of Italy on older people with dementia. They keep extremely good records from nursing homes there of the patients, of their diagnosis, their activities, daily living, and their feeding ability and nutritional status. So first of all, Alvisa carried out a 5-year retrospective regional study. This had records from over 13,000 patients. So these are huge gold standard studies, if you like. And she looked back to try to predict from this work what the incidence of the predictors were of self-feeding dependence amongst older people in nursing homes. And what she found is that at the individual level, increased functional dependence raised the proportional odds ratio by over 4 times of increased dependence in self-feeding. So any problems with functional dependence increased self-feeding. That makes sense. The more dependent the patient is, the more they rely on being fed. But clearly there are lessons there for clinical staff to know this, to know that the more dependent a patient is generally, the more dependent they may be specifically regarding self-feeding. And again, not surprisingly, the degree of cognitive impairment, in other words, the degree of dementia, the lack of social interaction, occurrence of other markers like pressure sores and comorbidities, as well as clinical instability and time, the time since diagnosis, all raised the risk of self-feeding dependence progression. So anything that's associated with dementia is also associated with the risk of self-feeding. Again, the lesson here is that to know that the ability to feed oneself is something that will decline in older people with dementia, and it's associated with other comorbidities. And then at the nursing home level, this was at the level of managing the home, an increased number of beds emerged as a factor which also increased the proportional odds of dependence and self-feeding. In other words, the bigger the nursing home, the more beds there were. And this suggests, of course, that the more beds does not necessarily suggest more staff. So presumably, the busier the staff are, then the more likely patients are to have difficulty with self-feeding. So these results are not that surprising, but they are in a sense definitive because they were studied rigorously on a large sample. So the next study that was carried out by the same team was to look at what encouraged self-feeding. So using a similar data set, Alvisa studied interventions maintaining eating independence in nursing home residents, and did this across several centres. And this study involved 13 nursing homes, and again a very large sample of patients. We interviewed 54 healthcare providers, and we used 13 focus groups here. This was to get the impressions from the staff who were experienced at working with these patients, what helped them to eat. So the results here were broken down as follows. The things that promoted and maintained eating performance for as long as possible included environment, in other words, by ritualizing the mealtime experience and controlling the environment. In other words, deliberately setting up an environment that would encourage eating. In other words, having a mealtime that was regular, that was quiet, that the residents knew when the meal was coming. Social, by actually structuring effective mealtime social interactions. In other words, by making mealtimes a bit of a social event rather than a clinical intervention. And finally, by individualizing eating care for each resident. In other words, finding out what each individual resident needed. Now, this is a qualitative study. These are the impressions of these staff. This is not quantitative data, but it does give us some insight into the kinds of things that could be done by clinical staff in order to help their patients or their residents to eat. Next, a quantitative study was carried out. And this study was a path analysis of the direct and indirect effects of a unit environment on eating dependence amongst cognitively impaired nursing home residents. Now, this study was carried out on over 1,000 residents. So again, it's large, it's definitive, and it's very rigorous. And the results of this study are as follows. The results of this study are presented as factors preventing eating dependence, in other words, factors promoting independence in eating. And these are presented under three headings: at the individual level, at the nursing care level, and at the nursing home level. At the individual level, eating dependence was related to functional dependence measured by the Bartel index. In other words, the better the functional independence, the more likely the patient was to be independent in feeding. That makes sense, and it ties in with the previous results. Eating in a dining room and not eating alone tended to promote self-feeding and also having a close relationship with family relatives. Now, there's a message here for us as clinicians to encourage the presence of family members during mealtimes. At the nursing care level, the greater the number of interventions aimed at promoting independence promoted independence in eating. So if nurses are actually actively doing things to promote independence, this does help the patient. So the message there is that we should be doing things to help them to eat. And at the nursing home level, aspects of the environment such as space, safety, lighting and outdoor access. The better these things were, all together and independently, the more likely it was to encourage self-feeding amongst residents. And of course the message there is to have nice nursing home environments. That's sometimes beyond our control, but some of these aspects such as safety and having access to the outdoors are well within our control. So a number of things there at the individual, at the nursing care level and at the nursing home level, all of which are capable of promoting independence in self-feeding. Now, the next study looks specifically at what nursing home environments can maximise eating independence amongst residents with cognitive impairment, looking at findings from a secondary analysis. Again, this is carried out on a sample of over 1,000 patients. Results here are quite straightforward and presented under 2 points. First of all, alongside individual and nursing factors, in poor nursing unit environments, residents with severe cognitive impairment showed increased eating dependence. So those which had low environmental scores were more likely to be dependent in eating. Again, that ties in with the previous study. And in contrast, better environments, similar matched residents showed maximal eating performance. I'm not going to go into these results in any great detail, but we've already seen how better nursing home environments, and there are specific measures of environment within nursing homes, improve eating amongst patients with dementia. So those are all the studies from my colleague Alvisa. They have given us, I think, considerable insight into the things that we can do individually and indeed collectively at the nursing home level to improve eating independence amongst older people with dementia. What I want to move on to now is another study which is quite different, and this is the study carried out by my PhD student Salma Riemann. And this study is summarised in a single paper that's been published from the study so far. We also published another updated systematic review. The systematic review, of course, included more studies than our original review in 2005. There's been a great deal of work done here. But what this particular study here was aimed at was evaluating a brief intervention for mealtime difficulty on older adults with dementia. And what we did here was we carried out a study using single case study methodology, and we used what's called an ABA design, which I'll show you in the results. So we used spaced retrieval here uniquely, and Salma used spaced retrieval to try and train the older people with dementia to eat better. And we did a study of something like 15 participants. Not all of them responded very well to the intervention. Some died before the intervention could be completely carried out, and we did find some relationship between the severity of someone's dementia and their ability to respond to this intervention. However, we did have considerable success with some of the patients, and I want to just to show you those results here. First of all, to summarize the results, we found that a mean time of over 100 hours was needed to deliver this intervention, and the number of sessions required for each patient required from about 90 to 222. That doesn't mean 222 interventions. This means sessions to actually get them responding to the spaced retrieval. There's a particular process that's gone through for that. And again, if anybody's interested in this more specifically, I can send the papers to them. The length of time that each participant retained information for all the sessions ranged from about 13 to 28 minutes. So with spaced retrieval, you're trying to increase the length of time for which they retain the information. So if you can prompt someone to feed properly using spaced retrieval, and they can keep the information for 28 minutes, for about half an hour, that's probably enough to help them to get through that particular meal time. And the study was carried out in an ABA. In other words, A means intervening, B means withdrawing the intervention, and A means reinstating the intervention. And for those patients who were able to go through the whole ABA process, we did manage to reduce the difficulty with meal times between the two phases of the study for most of the participants. There were some reasons why some were unable to continue with the intervention. And then we concluded that spaced retrieval is a useful method for reducing mealtime difficulties in older participants in the study who had dementia. So what I want to do now, and this will explain the study in a little bit more detail, is to show you a set of results from individual patients. I'll show you the first one and explain it in some detail, and then the other sets of results look almost exactly the same. So this is what an ABA study looks like on an individual patient. You can see there are three phases demarcated as A1, B, and A2. Phases A1 and A2 are identical in the sense that there's no intervention during that phase. We just study the person's feeding difficulty. This was done using the EDFED score. And in the B phase, the spaced retrieval was implemented. And you can see clearly in this patient and in all the patients I'm going to show here, and these were all the patients who completed all three phases of the study, that the feeding difficulty declines during the intervention phase. Now in this patient it went back up again in the final phase. And the bottom two graphs are measures of the mini nutritional assessment and the body mass index. And what you can see is that during the intervention phases, the body mass index and the mini nutritional assessment scores increased. So not only are we having some effect here on the patient's behavior, we are quite remarkably having some effect on their nutritional status. So that was the first patient. They're presented separately in separate figures. In the second patient, you can see a similar pattern during phase A, the A1, when there's no intervention, compared with phase B, where there is an intervention. The difficulty with feeding decreases and the nutritional markers increase. And you can see in this patient that during phase A2, that the effect of the intervention was sustained. In this patient, there wasn't a great deal of difference between the phases A and B, certainly in terms of the pattern, but the mean difficulty declined somewhat. You can see there's a lot of variance here, but the interesting thing is that in phase A2 the effect was in fact sustained. And again, the corollary to that is that in the bottom graphs, the nutritional markers all increased. Again, similar pattern in this patient with a slightly sustained effect of the intervention. Again, this patient very successful in the sense of a great decline between phase A and phase B in the mean level of feeding difficulty, and this was sustained very nicely in phase A2. So this is not just an effect of the intervention, there is some long-term effect on the patients as a result of the intervention, which is it's very pleasing, in fact, to show that you can actually do something to alleviate. So quickly, this patient, similar pattern between phase A1 and phase B. However, the level of difficulty did increase again in phase A2. Also, the concomitant nutritional markers are all improved in this patient. So the relationship between the feeding difficulty and the nutritional markers here isn't tied in exactly, but we don't observe a greatly sustained effect, but we do notice an improvement in nutritional markers. And final two patients, again in this patient the level of difficulty bounced back again to the original level and the nutritional markers fell. So this is one patient where the intervention was effective between phase A and phase B but wasn't sustained. And finally in this patient we see a sustained effect. So you can see that not all of the patients were equally successful. In nearly all of them we managed to reduce the feeding difficulty with the intervention compared with no intervention. Some of them were sustained, and it had a good effect in many of the patients on the nutritional markers. So this is well worth considering as an intervention. Now, I'm showing you someone else's research here. This is Helen Keller, who worked with Susan Slaughter at the University of British Columbia in Alberta in Canada. And they did a large nationwide study of food intake in residents living in long-term care. And I'm showing this because in this study they used the ED-FED scale as one of their outcomes. And what they were able to do was to do the following. They were able to tie in a unit score on the ED-FED to the number of kilocalories per day that a patient lost. If they had a higher score on the ED-FED, more feeding difficulty, they had a decrease in kilocalorie intake of 63 kilocalories per day and also 3 grams per day of protein. Now, what we did was use this particular score to try and look at how the ED-FED improvements on average in our study were actually helping to increase kilocalorie intake. We only looked at the kilocalories intake here. So what we did was we did an economic analysis of this, and I'm just going to present that economic analysis and then I'll be summarize and finish the session. So this is the result of our economic analysis. First of all, we looked at the cost of nursing labour on average for the nurses who were involved in the study. We estimated this is using UK currency at £40 per hour. We called that A, and then we looked at the length of the intervention on average, which was about 105 hours. And then by multiplying A by B, we arrived at C, which is £4,200 for the total cost of an intervention. Then we looked at the value of 1 unit change in the ED-FED score, which is a change in kilocalories. We called this D, and we know that to be 63 kilocalories. So we then looked at the mean decline in the ED-FED score between the two phases of the study. We called that E. That's between A1 and E2, and we worked that out at being 1.36 units. So using those figures, we calculated that the the change in kilocalories in total were 86 kilocalories, and the cost of that was something like £50 per kilocalorie. And that works out at around 400 RMB. But of course, the costs of nursing labour may be very different in our two countries. So we were able to put a figure to this, and we didn't make any decision ourselves as to whether this is a cost-effective intervention. We would have to leave that to managers and health economists to tell us, but at least we've been able, through this study, to provide some crude information on the effectiveness and the costing of using spaced retrieval to help to prompt older people with dementia to eat better at mealtimes. So to summarise the session, first of all, as I made a point at the beginning, we're unlikely to see a decline in the numbers of people with dementia in the next few decades. Problems associated with dementia, for example, mealtime difficulties, will therefore increase. And we've seen that it's possible to alleviate mealtime difficulties through a range of strategies. Specifically, these can be environmental, and at the group level, and also at the individual level. For example, the spaced retrieval work that I presented there. It remains for others to see if this is cost effective in the real world. So I'd like to once again thank you very, very much for this opportunity to speak to you. And if you want to contact me, that's my email there. You can also check my research record at ORCID. If there are any particular papers from these studies that you would like to see, I'm very happy to send them to you. I know you shouldn't in China, but you can if you want to follow me on Twitter. I just warn you, it's a personal Twitter, it's not a professional Twitter, but some people seem to like to follow me there. And finally, down on the bottom right, you'll recognize the WeChat logo. You're very welcome to scan that and to use that to contact me or to keep in contact with me if you prefer to do it that way. So finally, once again, thank you to colleagues at West China School of Nursing for this invitation to talk about research into mealtimes and older people with dementia. I've presented some of my own work here, and of course I must acknowledge that a lot of this work wasn't done personally by me, but by my PhD students, so I'd like to thank them. And once again, finally, thank you, and I hope that you found that helpful and useful.